Ramatipudi Hospital.
Hey, good morning, Chairman and all the audience. I am Dr. Chatchawan from Ramatipudi Hospital. I would like to talk about current concept of MCL reconstruction. The anatomy of the medial side of the knee is very important for reconstruction. There are three main ligaments that provide medial knee stability. The former speaker also talked about this, so I have to skip. The first is the superficial MCL, as you know. And the second one is the POL, or we call it posterior oblique ligament. It's combined the MCL and P. If combined MCL and posteromedial corner injury occur, patients may develop anteromedial rotational instability or AMRI. And the last one is the deep MCL. Okay. To assess the degree of medial knee injury, the valgus stress test is performed at both full extension and with the knee flex at 30 degrees. More medial gapping indicates more extensive ligament injury. And increased valgus gapping at 30 degrees of flexion but not in full knee extension indicates an intact POL. Also, if the external rotation is accompanied by anterior subluxation of the medial tibial plateau, which we can check for using the Slocum or dial test. Therefore, we should consider both the valgus and rotational instability in patients with suspected medial side knee injuries. And moreover, valgus stress radiographs are a reliable, accessible, and quantifiable method for evaluating medial compartment gapping. The MCL reconstruction is indicated in cases of subacute or chronic MCL injury. Typically, when the injury is more than 3 to 6 weeks old or when the patient presented with poor MCL tissue quality. The MCL reconstruction can be used to protect the MCL healing after repair in case of poor tissue quality, allowing for early rehabilitation. This is called MCL augmentation. Additionally, MCL reconstruction can be performed to replicate the MCL. Both the graft and the fixation strength are suspected. We can divide the MCL reconstruction technique into three categories. First is the anatomic medial knee reconstruction. The most familiar technique is the Laplace technique, which reconstruction both superficial MCL and POL. With a suture anchor fixation at just distal to the medial joint line, represent the deep MCL. The clinical and radiographic outcome were very good. The second group is the non-anatomic medial knee reconstruction, such as single bundle reconstruction on the left or triangular double bundle posteromedial reconstruction on the right picture, which also gave a significant improved valgus stability. This is the other technique for this group, but there is in this kind of reconstruction there is some remaining incidence of AMRI. The last one is the non-anatomic tendon transfer medial knee reconstruction or LIN technique. This is the popular one. This technique also has significant clinical improvement, but the radiographic outcome was not so well. As you know, there is many techniques. Overall, based on complex anatomy of the medial knee, it is unusual to reconstruct the POL and posteromedial complex. And multiple MCL reconstruction techniques exist, varying in graft choice, fixation method, bundle configuration, tensioning protocol. These variations address the complexity of medial knee injuries. Most techniques ignore the deep MCL reconstruction. This is for example for the recent technique from Egypt in 2022. Describe a technique to reconstruction both the superficial and deep MCL in the setting of anteromedial knee instability. Right? It is a very complex technique. This is interesting. The paper from HSM 2024. This is the cadaveric study compare 5 MCL reconstruction technique after resect the superficial MCL and deep MCL. They compare the 5 technique. First is the superficial MCL on the left, and next is superficial MCL reconstruction in the blue tape combined with the deep MCL reconstruction. The middle one is the deep MCL reconstruction, and the next deep MCL reconstruction with the short construct MCL reconstruction, and the last one is short construct reconstruction. The result is after they loaded anterior translation, external rotation, varus valgus, and AMI loading, they found that the contemporary MCL reconstruction technique failed to control the external rotation, and therefore AMI and AMI as they use a long superficial MCL graft and do not address the deep MCL. So the deep MCL is very important. This is a recent study from 2022, compare the triangular reconstruction with the superficial MCLR and POL advancement in grade 3 MCL injury patient. The left picture is the superficial MCL and POL reconstruction. And the right side is the other technique that they use the superficial MCL reconstruction with the POL advancement. Both techniques present good functional results. However, the advancement technique showed greater friction loss. For example, in this my patient, he had chronic MCL medial side laxity at 30 degrees of knees flexion. So we perform only a superficial MCL reconstruction, harvest the semitendinosus tendon and keep its tibial insertion intact. Then flip the graft to make it bigger and identify the isometric point on both the tibial and femoral side. Fix the graft on the tibial side with the bone staple and pass the proximal end of the graft underneath the medial soft tissue and fix it at the femoral insertion with a bioabsorbable screw. For the take-home messages, the diagnosis tools are very important. We have to evaluate both coronal and rotational instability. The straight radiograph and MRI are helpful for this evaluation. Understanding of the anatomy of medial side knee is mandatory for performing the anatomic reconstruction. But unfortunately, it is unusual to reconstruct the posterior oblique ligament or the posteromedial corner. Instead, my approach is to attempt to placate or retention the existing POL tissue as much as possible and supplement with the tendon reconstruction. Thank you.